I'd like to express my gratitude to the Motor Neurone Disease Association of Victoria for the Nina Buscombe Award, which enabled me to come to both this meeting and the conference. Voluntary assisted dying became available in Victoria in mid-June of this year. So it's too early to have any research or any data, but this presentation will outline the process taken to get the legislation happening. I'll give you a brief overview of the legislation and some of the implementation process, and then talk about some of the challenges that we've already experienced. For those of you not natives, I'm talking about this part of Australia, Victoria. It's a very small state, but it has a significant population for the geographic area. Victoria is the only state in Australia to have voluntary assisted dying. So the first comment to make is that voluntary assisted dying didn't happen in isolation, that there were various other pieces of legislative work that contributed towards voluntary assisted dying getting onto the political agenda. I won't go through them, but just to note, the Charter of Human Rights, changing the Powers of Attorney Act, and the palliative care and end-of-life strategy. The process for addressing voluntary assisted dying in Victoria was a relatively lengthy one through the parliamentary process. You'll note that in their report, many of the recommendations concerned other aspects of end-of-life care, and that there was one recommendation about assisted dying, and it seemed that over the subsequent years that was the one that got most of the attention. Then there was a ministerial advisory panel that was formed to consult very widely with the community about how they would like the legislation to be shaped. And then the Parliament voted on the legislation in late 2017, and there was an 18-month implementation process until the legislation became available this year. So there are three parts to the Act. There's the eligibility criteria, the request and assessment process, and the governance, and I'll go briefly through each of those. So the eligibility is quite stringent, and all of those criteria up there must be met. And for this audience, down the bottom of the slide there, you can see that the death is expected within 6 months, or for those people with neurological conditions, it's 12 months. And probably the most important is the bottom sentence, that the person is suffering in a manner that cannot be relieved in a way that they consider to be tolerable. There are three parts to the request and assessment process. The first request is an oral request to a medical practitioner who may become that person's coordinating medical practitioner and sees the process right through from beginning to end. There is a second medical practitioner involved, who is the consulting medical practitioner who undertakes a second assessment. And the second request is a written request that's signed by two independent witnesses and is given to the coordinating medical practitioner. And then there's a final verbal request, again to the coordinating medical practitioner, and there must be at least 9 days between the first and the last request, unless there's a sense that the person may die within that time. If the person's eligible, the coordinating medical practitioner applies for a permit to prescribe the voluntary assisted dying substance. If the person is able to self-administer, they have a self-administration permit, and that's the main aim of the legislation. However, there is allowance for someone who is not physically able to administer the medication themselves or digest the medication, in which case they apply for a practitioner administration permit. There are two roles for medical practitioners, as I briefly explained, and these are the only roles that are prescribed in the Act. No other health professional roles are prescribed. So the coordinating medical practitioner takes the main role, and as I said, they see the process through from beginning to end, and the consulting medical practitioner only has the role of performing the second assessment. Both of them must undertake assessment to have a view about aspects, as you can see there, their eligibility, that they understand, the person understands what they're requesting, that they're acting without coercion, and that the request is enduring. There are some limitations on the sort of medical practitioners who can participate. They need to be specialist medical practitioners, and that includes general practitioners. Between them, they must have at least 5 years post-fellowship experience and experience and expertise in the person's disease or illness. They must be a fellow of a specialist medical college, and that includes the College of General Practitioners, and complete an online training module before they can be involved in conducting an assessment. Health practitioners are not required to participate. We have conscientious objection enshrined in all Victorian law. A health practitioner is not able to initiate a discussion about voluntary assisted dying. There are protections for health practitioners who act in good faith in accordance with the Act and not provide life-sustaining treatment that hasn't been requested if they believe the person has accessed voluntary assisted dying. And there are a range of offences under the Act for such things as initiating a request. Conscientious objection is covered very closely in the Act, and it's not sufficient to say, I'm a conscientious objector, I don't want to be involved. There needs to be some thought and consideration into what aspects of the legislation someone doesn't want to be involved in, and you can see there that's a quote directly from the Act. I won't go through this slide, but suffice to say that there are also very stringent reporting processes. In fact, we have an online portal where all of the assessment processes and all of the permits are all there to be seen so that the process can be tracked. So at each stage of the process, someone has an eye on what's happening, and all of those forms are according to what has been provided in the Act. The Voluntary Assisted Dying Review Board oversees the Act, and we have the responsibility to report to Parliament every 6 months. And that community reporting is very important in terms of being accountable to the community for what's happening. So over 2018 and half of 2019, there was a significant amount of work done to address aspects of the implementation of the Act. It was always seen that voluntary assisted dying would happen within existing healthcare. It wasn't going to be something like the Swiss model where there's a little house down the street. It was to be within health services and the sort of services that are already being provided. So we worked on, for example, guidelines and policies that might be able to be adapted rather than developing new ones. So we had 5 working groups, a group looking at the model of care, a group looking at guidance for health practitioners, the training for medical practitioners, the medication protocols, and the consumer and community information. And it looked a little bit like this. So the 5 groups reported to a task force, and then there were numbers of other pieces of work that needed to be done, including looking at an end-of-life gap analysis, which was important in terms of understanding the palliative care gaps. So, for example, the model of care group developed a 3-part model that services could decide where they fitted. So if a service was going to provide voluntary assisted dying, they needed to already have the resources there of staff who worked with people at the end of their life, who were able to have those conversations and felt comfortable and had the other resources that were available. through to a service that chooses to be a Pathway C, where they don't routinely look after people who are at the end of their life, and so they would be mainly an information and support service, so often referring people to other health services. So the medications group developed the protocols, and the government decided that there was to be a single pharmacy service that would manage the medications right across the state. And even though the state looks small, it's about a 3-hour drive to the furthest border, so it does have its issues. So the statewide pharmacy service has responsibility for all aspects of the medication, and they deliver the medication to the patient and undertake some education with them about what to do with the medication. So some of the clinical challenges that we've needed to address with health services, firstly and importantly, is to decide which one of those pathways that the services would choose to be part of, and be upfront about whether they were going to be providing voluntary assisted dying. There was no compulsion about whether they would or not, but they needed to make that decision. But whether or not they chose to or not, in preparation for the legislation, it was looking at aspects like how staff would be educated and supported in responding to patients' requests for voluntary assisted dying information, and if voluntary assisted dying would or would not be provided, what model of care they would use, and the sort of staff education and support if voluntary assisted dying was going to be provided. Many organisational challenges have been anticipated but also have emerged. So the communication and information provision, the implementation task force had a process whereby there was a designated person from each health service who was the key contact person, but we since realised that sometimes the information was just kept within a certain group of people, or the clinicians who were working on the palliative care unit, for example, didn't seem to be informed of what was happening. So the best laid plans of setting up communication didn't always seem to work across the board. As I said before, the sort of policies and procedures and guidelines that needed to be developed around voluntary assisted dying sometimes could be built on existing policies and guidelines. So trying to reassure health services that this wasn't reinventing the wheel necessarily, but there were policies and guidelines, for example, about supporting staff with difficult situations. This is another difficult situation, so you might be able to transfer some of that information. Being familiar with the documentation and the process, so you may have gathered that the process is fairly arduous. It's not meant to be crisis management. This is a considered process that takes a bit of time. So if someone's in the last few days of their life, you wouldn't be recommending this. And so communicating the need for staff to be very familiar with the process, with the Act, and how the Act is acted out in clinical environments. As I said, the whole process is online, so the IT systems needed to be brought into line so that they could talk to each other, I suppose I'm saying, and that the request process could be tracked. Some of the faith-based services have had challenges, as you can imagine, and if a patient requests voluntary assisted dying in a service that is a faith-based service or has chosen not to be involved in voluntary assisted dying, what are the processes whereby a person's need can be met and they're not abandoned or shunned? And then the patients themselves, how they are going to be supported through the process. It was imagined that most patients would be accessing voluntary assisted dying in the home setting, but it's a bit early to tell with the statistics at the moment, but there are some who have accessed the legislation in an inpatient setting, and so how they are supported on a ward. Do you find a single room? What do you do with the family? All of those sort of very practical questions. And then the challenges for clinicians. So we've very much put out the message that responses need to be compassionate and respectful. There's no room for someone to say, I can't talk about this, I don't agree with it, because your opinion doesn't matter to the person who's making this request. They are looking for information. So challenging people to find ways to respond, but not being defensive. Challenging them to undertake individual reflection on their own personal responses. Making sure that they are guided by their personal and professional beliefs and the guidelines and their statutory obligations in terms of duty of care. Recognising that end-of-life discussions are very broad and may include discussion about palliative care, about symptom management, and by the way, it may include voluntary assisted dying. So keeping the conversation broad in meeting people's needs. And we've got a number of voluntary assisted dying navigators who are working around the state with clinicians, with people who make requests for voluntary assisted dying, and with health services to help connect them with the people that they need to be connected to. So in summary, voluntary assisted dying is really only for a few people. Around the world, that's the experience. But end-of-life care and palliative care is for most people, can impact their end of life. So we need to keep in mind that perspective. This new legislation does require time to become established, and as I've alerted, there have been a number of issues already, a number of challenges, but it is early days. We need to be very alert to the dissemination of information, both to the community and people who are looking for assistance in voluntary assisted dying, but also with clinicians who are out there helping them. In a number of places around the world, it's been helpful for providers to establish some networks so that they can share their experiences and be supported, and that's something that we've done in Victoria as well. The review board needs to be very open and transparent about the work that they are doing, and as I said, there is a mandatory reporting to Parliament every 6 months, and there's already significant interest from researchers into looking at how we're going. And then through our reporting to the community, reporting to Parliament, making sure that we report to the community. So how do we make sure that our messages get out there to people who are interested? So thank you.
Questions? In the back.
Thank you. Nip Thompson from Melbourne, an academic physician. Thank you, Margaret, for an excellent presentation. A few years ago, we were invited to lunch by some friends, and we met some other people there, and as they were leaving, we noted that the woman was having some trouble climbing the step to get out of the house. And to cut a long story short, she volunteered that she had been recently diagnosed with MND. We didn't know what happened, but 3 months later we found out from our friends that she had gone to Switzerland for assisted dying. So I wondered how common this may well be in other neurodegenerative disorders as well as MND, both in Australia, and maybe Rachel might have some information about from the United Kingdom about how common this is, or whether it's something that's very difficult to track.
Do you mean specifically for MND or for...
Well, MND specifically, but of course other neurodegenerative disorders, which are part and parcel of the new Victorian legislation, of course, with a 12-month waiting period.
Yes. Well, it's too early to talk about our statistics, and I'm sure there must be some research that I'm not aware of isolating the person's illness But I do know that in most countries where there is euthanasia or voluntary assisted dying, it's about 1% of the overall deaths in each country. It doesn't vary very much from that, but I'm not sure of the specific MND statistics. Yeah.
There was another question over here.
As a speech pathologist, it's quite a challenge knowing how the written and the oral, consent and then also requests can be made. When it comes to someone who has dysarthria or an issue with communicating, is there assistive technology that's allowed to be used?
Yes.
Okay.
Yes, we spent a lot of time thinking about the limitations of people, particularly who can't communicate. So that's all incorporated.
There's another question.
Thank you, Jim Howe, from the statewide service in Victoria. Just to answer the question on neurodegenerative disease and voluntary assisted dying, in almost all the other jurisdictions, people with cancer are the largest number by far who go into voluntary assisted dying, and neurodegenerative disease make up a very small number, but of the neurodegenerative diseases, motor neuron disease makes up the largest number. But exact numbers varies across the jurisdictions, and I couldn't give you any percentages.
Thanks, Jim.
There's one other question, and then we have a break.
Hi, thanks for that. I'm just wondering, we're working as support coordinators with M&D Victoria, and we often get asked about registries. So we send people off to speak to the navigators, but one of the questions is always, is there a registry of doctors that is getting made up?
No, there isn't. Such a thing might be misused, so no, there isn't. But again, given its early days, it's word of mouth at the moment, and the care navigators have been absolutely pivotal in connecting those that need to be connected. And I'm sure they will have in their heads people already, particularly in rural areas. But I think putting people on a list is probably not the way to go.
All right. Thank you very much.